There's a decent chance something in your medicine cabinet right now shows up in actual dementia research, and almost nobody talks about it outside a medical journal. Doctors hand out allergy pills, sleep aids, and heartburn medication like candy, and all three keep showing up in studies on cognitive decline. Most of what's online about it is either buried in a journal nobody reads or blown into a clickbait headline. I read the actual research so you don't have to guess, and I'll show you exactly how I audit my own cabinet by the end. Let's get into it. Everything here comes from published research, and none of it comes from a medical degree, because I don't have one. So if something in this video makes you look twice at your own cabinet, take that to your doctor as the next move. Let that conversation happen before you decide anything on your own tonight. 3 categories of medication keep coming up whenever researchers study drugs and brain aging. The first is anticholinergics, a group that includes a lot of older allergy pills, some sleep aids, and bladder medications. The second is benzodiazepines, the anti-anxiety and sedative drugs doctors sometimes prescribe for short-term stress or insomnia. The third is proton pump inhibitors, the daily acid reflux medication millions of people take without ever questioning it. Peter Attia has covered part of this on his own podcast, walking through benzodiazepines for insomnia and the older antihistamines people use to knock themselves out, plus his own anticholinergic worries. I couldn't find anyone else grouping all 3 categories together the way I'm about to, so this framework is mine, not his. When I actually went through my own cabinet doing this exact audit, I found something that surprised me. I'd been leaning on the same over-the-counter sleep aid a few nights a week for years, the kind you grab off a drugstore shelf without reading past the word sleep on the box. I had no idea it fell into the same anticholinergic family as the drugs showing up in these dementia studies. That's the moment this stopped being an abstract research topic. It turned into something I actually needed to think through. So I started digging into what the studies actually say instead of reacting to a scary headline. The numbers on this are bigger than most people expect. Estimates vary widely, but somewhere between 1 in 10 and 1 in 3 older adults are on at least one medication with anticholinergic properties. That could be an allergy pill, a bladder drug, or a sleep aid, often for years without anyone revisiting it. Then there's the over-the-counter side, where roughly 1 in 20 American adults reaches for a sleep pill or supplement most nights of the week. That's a lot of people quietly building up exposure without ever making a conscious choice to do it. That scale is exactly why researchers keep circling back to these 3 categories instead of some obscure drug almost nobody takes. The reason years on the same pill matter at all comes down to one brain chemical called acetylcholine. It's involved in memory and learning, and it's the exact same chemical that drops off in people with Alzheimer's. The actual drugs prescribed to treat Alzheimer's symptoms work by boosting acetylcholine levels in the brain. Anticholinergic drugs do the opposite. They block that same chemical, which is exactly why they're so good at drying up a runny nose or calming an overactive bladder. Older, first-generation antihistamines also cross into the brain more easily than newer ones, which is part of why researchers keep flagging them specifically instead of every allergy pill on the shelf, a mechanism that clean still doesn't prove anything on its own. So the real question is, what happens to people who actually take these pills for years? A large cohort study out of the Adult Changes in Thought project followed thousands of older adults for years. It's the one that actually made me sit up. It found that higher cumulative doses of strong anticholinergics tracked with a clear dose-response increase in dementia risk. The risk showed up whether the heavy use happened recently or years earlier. That suggests the effect doesn't just disappear the moment you stop. A UK study matched tens of thousands of dementia patients against healthy controls, and the numbers held up there too. The heaviest lifetime users faced roughly 50% higher risk of dementia overall, though specific subclasses like antipsychotics and bladder medications climbed closer to 70%. Some subclasses, though, showed no meaningful bump at all. Gut antispasmodics didn't move the needle in that same study, which is exactly why I stopped treating anticholinergic like one blanket risk. More recent research zoomed in on bladder medications specifically, since those tend to get prescribed for years without much reconsideration. One large primary care study found any use of these drugs carried a modestly higher dementia risk, and men showed slightly more risk than women. A second study looked at repeat prescriptions and found the same dose-dependent pattern. People on more than 6 months of consistent use showed a somewhat higher rate than people who only used it briefly. If you've been on the same allergy pill or bladder medication for years without ever revisiting whether you still need it, that's worth bringing up with your own doctor. It's a genuinely useful conversation, not something to quietly worry about alone. When people hear the word anticholinergic, they picture an allergy pill and stop there. The category is much wider than that, and that's the part that catches everyone off guard. Motion sickness tablets sit inside it, so do a lot of the muscle relaxants handed out after a back injury, along with several of the older antidepressants that are still prescribed today. Some medications used for Parkinson's and for certain psychiatric conditions carry a heavy load too. Those drugs still do their job, and a prescription you actually need is worth keeping. The load can simply show up from places you'd never think to count. Then there's the bigger blind spot. When a doctor asks what you're taking, most people list the prescriptions and consider the question answered, but the nighttime cold medicine doesn't come up. Neither does the drugstore sleep aid, or the motion sickness pill for long flights, or the allergy tablet somebody has taken every spring since college. A burden scale doesn't care whether a pill came with a prescription label, and some of the over-the-counter stuff rates just as strongly anticholinergic as the prescription drugs in the same family. That was the genuinely uncomfortable part of my own audit. The pills I almost didn't bother counting were the ones I'd never mentally filed under medication at all. What finally made me count every last pill in that cabinet was seeing what heavy long-term use looks like on a brain scan. This shows up as more than a percentage in a table. Researchers have found smaller brain volume and lower glucose metabolism in memory-related regions among heavy users. Glucose metabolism is basically how much energy those brain cells are burning. A lower number there means less activity in the areas that handle memory. That's a physical difference you can actually see on a scan, not just a pattern in a spreadsheet. It's part of why this specific category gets taken more seriously than the other two. If you're on more than one long-term prescription, that combined burden is a more useful question than whether any single pill on your list is flagged on its own. Ask your pharmacist if they can run a burden check across your full medication list, not just the one drug you're worried about. It takes a few minutes, and it catches a hidden stacking effect a doctor juggling 10 other things on your chart might miss. There's also a low-tech way to notice a heavy load without any scale at all. I like it because your own body reports it for free. Acetylcholine doesn't just run memory, it also runs saliva, digestion, and the fine focusing of your eyes, so blocking it tends to leave a signature. Dry mouth that never quite goes away. Constipation, blurry near vision, and a foggy first hour after you wake up all point the same direction. You might have been quietly living with 2 or 3 of those for years and blaming it on your age. That's worth mentioning at your next appointment. It's not proof of anything, and plenty of other things cause the same symptoms. It's just the cheapest signal you'll ever get that something on your list is doing more than treating the thing you bought it for. The obvious next question is whether any of this reverses when you stop. The honest answer is that nobody has shown it cleanly. When researchers pooled the trials on actually cutting people's anticholinergic load, they found a handful of small studies and no clear cognitive benefit at the end of them. That surprised me. Dropping a heavy pill and feeling sharper a couple of weeks later is a story you hear constantly, including from me. The structural side is a harder question still. The big cohort study I mentioned earlier found the elevated risk showing up in people whose heavy use had ended years before. So nobody can promise you a reset. What you can do is stop adding to the pile from here, and that alone is worth a conversation. Now here's the safety part, because this genuinely matters more than anything else in this video. You do not stop a benzodiazepine on your own. Coming off one abruptly can be medically dangerous, and it needs a supervised taper with the doctor who prescribed it. The same caution applies to older antidepressants that happen to sit in the anticholinergic family. Those treat something real, and stopping cold has its own consequences. If a pill on your list worries you after watching this, the move is a phone call to your doctor, not an empty spot in your cabinet tonight. My own version of this was a lot less dramatic. I dropped the drugstore sleep aid and replaced it with the boring stuff I already knew worked, which mostly meant a colder room and no screen in the last hour. The first few nights were genuinely worse, and I won't pretend otherwise. After about 2 weeks, I was falling asleep faster than I did on the pill, and the groggy first hour of my mornings quietly disappeared. That's one person's experience and not a study, but it did make me realize the pill had been solving a problem I'd stopped trying to solve properly. Coming off, it was that painless for me, but I can't promise you the same 2 weeks. The same pill doesn't land the same way in two different brains. Part of that difference is written into you before you ever open a medicine cabinet. People who carry a specific gene variant already tied to higher baseline Alzheimer's risk seem to react differently to these drugs. In one study of cognitively normal older adults, the people taking an anticholinergic were noticeably more likely to slide into mild cognitive impairment. Carriers of that variant showed a noticeably larger effect than non-carriers. That was ordinary use rather than heavy use, which is the part that got my attention. Other work hasn't consistently reproduced the same interaction, so this is a signal and not a settled fact. Attia has talked about this variant extensively in the context of personalized risk. It's a good example of why two people can take the same pill for the same number of years. They can still land in completely different risk categories. If you already know your status, that's worth mentioning to your doctor. It might shift how urgently you want to revisit a long-term prescription. If you don't know your status, I wouldn't tell you to go test for it tomorrow. It's just a real variable sitting underneath a lot of these population numbers that most headlines never mention. That's the anticholinergic picture as a whole, and it's still the sturdiest case of the three categories. The dose-response pattern holds up well in American and British data. It shows up in Taiwanese data too, though the results there are more mixed. One national cohort found no overall link until you got to the heaviest, longest users. What it doesn't do is hold across every drug in the family, since some subclasses show no effect at all. The next category behaves nothing like that. Benzodiazepines are where the research gets messier and honestly more interesting. The same data can support two opposite conclusions, depending on who's presenting it. A large study that mined years of medical databases found benzodiazepine use associated with dementia. Long-acting versions showed a somewhat stronger link, though the difference wasn't statistically significant in most reviews. Then researchers pooled together every published review on the subject, which is about as wide as evidence gets. The added risk came out somewhere between roughly 40 and 80%, depending on which meta-analysis you look at. The researchers rated their own confidence in that number as low, sometimes very low. Here's the problem baked into almost every one of these studies. Anxiety and insomnia are often early symptoms of dementia itself, showing up years before an actual diagnosis. Someone starts taking a sleep aid because their brain is already quietly changing. The study then ends up blaming the pill for something the disease started first. Researchers call that reverse causation, and it's exactly why this category still gets labeled complex and controversial in the most recent reviews. There's also a real difference between how most people actually use these and how the studies define long-term use. Taking something occasionally for a rough flight or a genuinely brutal week is a completely different exposure than taking the same pill nightly for years, without ever revisiting whether you still need it. Most of the risk signal in these studies comes from that second group, the years-long daily users, not the occasional user reaching for one during a rare bad stretch. There's one more thing about sedating sleep aids that rarely gets said out loud. Being knocked out is not the same thing as sleeping well. Sedatives push you into sleep fast, but they also shift the shape of your night. Researchers keep finding they cut into the deep and dreaming stages that actually do the repair work. You can spend 6 months on a pill and technically log 8 hours. You still wake up feeling like you were run over. That mismatch is what pushed me to stop treating a sleep problem as a pharmacy problem, because the pill was quietly hiding the thing it was supposed to fix. Some researchers have tried to fix that timing problem directly, and I actually like this fix. They build a lag into the study. That way, prescriptions written 5 or even 10 years before a diagnosis don't get counted as a cause. The logic is that quiet cognitive symptoms are often what pushed someone toward a sleep or anxiety prescription in the first place. Once that window stops counting, the association shrinks in some analyses and holds up in others. Bottom line, nobody has fully settled this one yet, and I'd rather tell you that than pretend otherwise. Every number I've given you so far has been a relative risk, and relative risk without context is where most scary headlines live. 70% higher sounds terrifying until you ask what the baseline actually is. In your late 60s, the chance of developing dementia over the next 10 years sits at only a few percent. A 70% relative increase there moves you by a couple of points, not by 70. The catch is that the baseline climbs steeply as you age. By your late 80s, that same relative number is stacked on top of a far bigger starting risk, and it stops being a rounding error. A real absolute increase still matters when the outcome is dementia. So I want you reading every one of these headlines with that translation built in from now on. Relative risk sells clicks, while absolute risk is what actually tells you how far your own odds moved. Run that same translation on the third category, and the numbers don't just shrink, they mostly disappear. Acid reflux medication got the scariest headlines of the three, and it's also the one where newer research pulled back the hardest. One approach leans on people's genetics instead of just tracking who takes what. That strips out a lot of the noise that muddies regular studies. That kind of study found no solid evidence that proton pump inhibitor use causally raises dementia risk. A separate review pulling together dozens of different studies came back inconsistent. 2 large prospective cohorts followed older adults over years and found no meaningful jump in dementia or mild cognitive impairment tied to cumulative PPI use. A few other cohort studies have found a modest link, so this one isn't fully settled either. This is the category I'd point to whenever someone says every scary pill and dementia headline is exaggerated. Sometimes it actually is. The obvious question by now is why nobody mentioned any of this at your last appointment. The real reasons are a lot more mundane than a cover-up. Prescriptions have enormous inertia built into them. Once a drug lands on your chart, it tends to stay there until somebody actively questions it. Nobody really owns your full medication list either. One doctor treats the reflux, another handles the allergies, and the drugstore stuff never enters the record at all. Add a 15-minute appointment already packed with whatever brought you in, and the long-term cognitive question simply never gets its turn. When your doctor stays quiet about it, the internet happily fills the silence, and that's where one very specific number keeps coming from. You've probably seen the version of this story that throws around dementia at 45 like it's already happening to healthy people on allergy pills. That framing isn't backed by anything I found in the research. Almost every study on these 3 drug classes enrolls adults 55 and older, often 65 and older, so exposure in your mid-40s has basically never been measured. That's missing data rather than a clean bill of health, and I'd rather say that plainly than pretend either direction is proven. What the research does have for younger adults points somewhere else entirely. A study followed over 900,000 women between 40 and 60. The ones with the largest waistlines had a meaningfully higher risk of young-onset dementia than those with the smallest. If you're in your 40s and genuinely worried about your brain, your waistline is a bigger lever right now than your medicine cabinet. That doesn't get the cabinet off the hook though. It just makes the cabinet the cheapest item on the whole list to deal with, and cheap wins are the ones I do first. Here's my actual framework, and it's boring on purpose. I look at duration first, not the drug itself. A week of an antihistamine during a brutal allergy flare is nowhere near the same risk. Taking the same pill every single night for 15 years is a different story. I also look at whether there's a lower anticholinergic alternative for the same symptom. Some newer allergy and bladder medications carry a noticeably lighter cognitive burden than the older ones doctors have been prescribing for decades. Then I ask whether I'm actually treating a symptom I could fix another way through sleep habits or diet, instead of reaching for the same pill on autopilot for years. You don't stop taking something your doctor prescribed because a guy on YouTube found a study. You walk into your next appointment with sharper questions instead. Write your actual list down before you go in, every pill and every supplement. Most people forget half of what they're taking the second they sit in the chair. Ask how long you've realistically been on something and whether a lower burden alternative exists for your specific case. Then find out if the symptom you're treating has even changed since you first started. Most doctors won't raise this on their own yet, since pulling medications back is still more of a growing research field than routine practice. What does seem to work is you starting the conversation. Patients who bring it up themselves are more likely to end up with something actually taken off the list. While we're being honest about what moves risk in your 40s, the pill in your hand isn't even in the top few. Hearing loss you never got checked is a bigger lever. So is blood pressure sitting quietly high for your midlife years, along with how much you drink. All three of those sit on the list of modifiable risk factors that researchers think account for close to half of dementia cases worldwide. Sleep, to be fair, isn't on that list, even though I'd still fix it first for every other reason. I find that genuinely reassuring rather than depressing, because those are things you can act on this month without anyone's permission. Auditing your cabinet is worth an afternoon, and fixing the boring stuff is worth years. Anticholinergics are the one category actually worth paying attention to if you've been on one for years. Benzodiazepines are a genuine gray area that depends entirely on why you started taking one. And the proton pump inhibitor panic was mostly noise dressed up as a headline. So if any of these three categories are sitting in your cabinet right now, the smart move sits between panicking and ignoring it. Pull your actual list together this week and bring the same three questions I just walked through to your next appointment. That's the whole audit, and it costs you 5 minutes instead of years of guessing. Either way, that's a better use of 5 minutes than doom scrolling another dementia headline at 45. I'll see you in the next one.